Good afternoon, everybody. Thanks for joining us today in our cardiovascular grand rounds. Welcome, Dr. Bhatt, and thank you for being with us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you our moderator for this event, Dr. Daniel Izaza, medical leader of the Coronary ICU of La Cardio. Welcome, and thank you for moderating this event.
Muy buenas tardes a todos y muchas gracias por su participación. Mi nombre es Daniel Izaza y los estaré acompañando en la moderación de esta conferencia. Les recordamos que al conectarse a esta conferencia están autorizando el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la Ley 1581 del 2012 y nuestra política de datos personales, la cual pueden consultar en www.cardioinfantil.org. De igual forma, les informamos que esta conferencia está siendo grabada. El chat de preguntas se encuentra habilitado en la barra de participantes. Les agradecemos dejar allá sus inquietudes, las cuales resolveremos al final de la sesión. Un agradecimiento a Pfizer por vincularse como patrocinador. We welcome to these grand rounds. We are honored to be joined today by one of the most prominent figures in the cardiology field for the last 20 years. Dr. Deepak Bhatt is an interventional cardiologist. He's director of the Interventional Cardiovascular programs at Brigham and Women's Hospital and professor of medicine at Harvard Medical School. He has received many awards that will take all the available time to list, but some of them include the Eugene Brownwell Teaching Award, the AHA Distinguished Scientist Award. He has been distinguished by a lot of scientific societies. He has been a principal investigator for numerous RCTs. And Dr. Bhatt is the author of the 2020 ACC Expert Consensus Decision Pathway for Anticoagulant and Anti-Platelet Therapy. And he's going to talk us today about the optimal antiplatelet and anticoagulant strategies in the atherothrombosis. Welcome, Dr. Bhatt, and go ahead.
Great. Well, thank you so much. It's wonderful to be with all of you. Really a privilege and a pleasure. So let me go ahead now and start my screen so we can get started on time. Just give me a minute here to pull up the slides and share the screen. All right, good. Let me confirm. Are you able to see my slides and hear me well?
Yes, perfect.
Okay. Terrific. Let me just get my timer here too, just so I don't speak for longer than you want me to speak. So I had put together a talk as requested on anti-thrombotic strategies, in particular anti-platelet and anticoagulant strategies, but specifically in atherothrombosis. Obviously, it's a very broad field. There's all sorts of indications for anti-platelet therapy and anticoagulant therapy, but I'm going to focus specifically on atherothrombosis. Before I get started, let me just speak to a little bit about my disclosures. So relevant to this talk and trials that I'll be covering is research funding that's paid to AstraZeneca and Bayer and Phase Bio for my roles in the Themis and Themis PCI and reverse it trials respectively, and also honoraria from Population Health Research Institute for my role on the COMPASS trial. So let's start first with the platelet side, then we'll move to the anticoagulant side of my talk. I think everyone in this audience realizes the important role of platelet activation and aggregation in atherothrombotic syndromes. And really by atherothrombotic syndromes, I mean situations where atherosclerosis and thrombosis are problematic, such as acute coronary syndromes, but also in patients, for example, who've had prior myocardial infarction or who just have advanced coronary artery disease. And in these sorts of circumstances, the platelets play an important pathogenic role. We've learned through the years that the ADP receptors are particularly important in terms of reducing platelet activation and aggregation. We first learned it with agents such as clopidogrel, not really clopidine before that, but clopidogrel is what brought the field forward by a huge leap. And then subsequently agents such as prasugrel and ticagrelor. But ultimately it's clopidogrel and what we learned about it that moved our knowledge of the P2Y12 receptor and the importance of its inhibition forward. Now, there's lots of trial data supporting dual antiplatelet therapy. For the sake of time, I'm not going to review all of that and focus on some of the newer concepts and some of the newer data. But it's been a long-standing debate just how long to continue dual antiplatelet therapy in patients for indications for it, such as patients with acute coronary syndromes or patients undergoing elective coronary stenting. The historical anchor has been 12 months of dual antiplatelet therapy, but more recent trials have suggested maybe shorter durations are good enough. And I think, as with all things in medicine, the truth is somewhere in between. It depends. It depends on the patient. And in general, I think for patients with acute coronary syndromes, better to go longer in terms of duration of antiplatelet therapy. That is assuming that they don't have a history of bleeding or aren't at high risk of bleeding. If they are, then probably shorter durations of DAPT are better. On the other hand, if they've got risk factors such as diabetes or renal dysfunction, maybe heart failure, maybe patients with previous stent thrombosis, those with peripheral artery disease, those factors would weigh more towards continuing longer term DAPT, 12 months or even longer than 12 months. And the coronary anatomy really does matter. If a patient has long lesions, small vessels, bifurcation lesions, complex coronary anatomy, disease in the left main coronary artery, those are situations, again, that would favor longer term DAPT just from the coronary artery disease, and then even more so if that coronary artery disease is treated with a lot of metal, that is with lots of stent implantation, which then raises the risk of stent thrombosis. Here, though, we're talking just about the risk of de novo coronary lesions, which these days are much more frequent even in stented patients than stent thrombosis, now that we've moved to second generation drug-eluting stents. So patients with complex disease, even putting the stent aside and stent thrombosis risk aside, just by virtue of needing multiple stents, that means that they must have severe underlying coronary artery disease, and that's what really drives their atherothrombotic risk. So all these different patient-related, anatomy-related, and even to an extent stent-related factors matter in terms of deciding how long to continue dual antiplatelet therapy. And even if we look at the most recent data, this is a meta-analysis, just came out in Circulation recently, even if we look at all the data to date in patients with drug-eluting stents after percutaneous coronary intervention, we find still that extended term dual antiplatelet therapy reduces the risk of myocardial infarction compared with even 12 months of dual antiplatelet therapy. So for the right patient, if we can find them, they really do benefit from longer durations of dual antiplatelet therapy. How can we figure out who the right patient is? Well, that's easier said than done, but one way is using different risk scores. This is an angiographic risk score. It's not necessarily one that you would actually use, but I think it provides some insight into how physicians intuitively can decide who might benefit from longer or shorter durations of DAPT. And the point here is with the higher number of high-risk procedural characteristics, the greater the benefit of extending DAPT for 12 months or more. You can see if there's zero angiographic risk factors, well, there's really little benefit versus just going 3 to 6 months for the DAPT duration. If there's 1 or 2 or 3 or more angiographic risk factors, well, then the benefits of longer-term DAPT really do become more obvious. And what do I mean by high-risk procedural characteristics? Here it's referring to things like long lesions, long overlapping stents, bifurcation, drug-eluting stents, the sort of things that raise the risk of stent thrombosis, but more importantly, patients that have that type of disease have a lot of atherosclerotic burden. And again, that's what really drives the increased risk and then potentially the increased benefit of protracted dual antiplatelet therapy. Now, what's come in vogue in recent years is this concept of net clinical benefit, that is lumping together ischemic and bleeding events. And as Gabriel Steg and I argue here, is there really a benefit to net clinical benefit in testing antithrombotics? We're actually saying in this piece in Circulation, no, we don't actually think that's a good idea. Obviously, looking at bleeding is important, but it isn't really fair to lump an ischemic stroke with a transfusion. Obviously, a transfusion is a bad thing. No one's saying that that's good. there can be some downstream consequences of that. But on the other hand, preventing a stroke is more important than causing a bleed. So if you lump all those together in some sort of net clinical benefit endpoint, it can obscure real benefits of protracted antithrombotic therapy, in this case, dual antiplatelet therapy, but this would also apply, say, to anticoagulant therapy or any form of antithrombotic therapy, where of course there's going to be bleeding. The real question is, do the ischemic benefits outweigh the bleeding benefits, or bleeding hazards, rather? So that was one way of looking at risk that I showed you in the angiogram, but here is another way, the PRECISE-DAPT score. So this is a more quantitative way for people that like risk scores of doing it. The previous way was just using an angiogram, sort of eyeballing it and saying, yeah, that patient has a lot of angiographic risk factors. But here, we're now looking at the PRECISE-DAPT score. It consists of 5 different elements: age, creatinine clearance, hemoglobin, white blood cell count, and previous spontaneous bleeds. And then it's calculated through a nomogram that you can go to online for free, and it determines whether the patient's high bleeding risk or not. If they're high bleeding risk, there you'd want a score greater than or equal to 25. You would want to shorten the duration of DAPT. But if the score is less than 25, there you want to go at least 12 months or possibly longer. And there you would expect the ischemic benefits to outweigh the bleeding benefits. So this is a way of using net clinical benefit that I was just alluding to, but in a way that sort of balances things out reasonably well. Now, you might look at age and creatinine clearance and say, yeah, that would increase the risk of bleeding. That's obvious, but it also increases the risk of ischemic events. So those aren't necessarily the most differentiating features. Hemoglobin, of course, a low hemoglobin is perhaps representing some sort of occult bleeding, but it also might just mean if the hemoglobin's low, and if the patient has bleeding, they're going to tolerate it less well than someone who has a normal hemoglobin to start. So that's useful. White blood cell count is just a measure of illness. The higher the white blood cell count, the sicker the patient. And previous spontaneous bleeds is a good one in this risk score, where if patients have had a previous bleed, well, then they're going to be at higher risk of a future bleed. Nothing predicts future bleeds like previous bleeds. And even if that previous spontaneous bleed was from a correctable cause, like a gastrointestinal ulcer where the endoscopist goes in and cauterizes the bleed, well, still that patient is at higher bleeding risk than a patient who's never had a spontaneous bleed. So that, I think, is a good feature. And in general, in patients that are anemic with a low hemoglobin, thrombocytopenic with low platelets, that have had previous spontaneous bleeds, there in general, if you don't want to calculate a risk score, I would say those are patients you do not want to use long-term dual antiplatelet therapy, and even if they're at high ischemic risk. Why do I say that? Well, here's another analysis. This is a meta-analysis looking at a bunch of different trials, randomized trials of longer and shorter durations of DAPT. And here, looking at patients stratified by the PRECISE-DAPT score. And what we're doing here is seeing exactly what we might be able to gather from the PRECISE-DAPT score in terms of figuring out who should or shouldn't get long-term DAPT. And there's a lot of patients in this pooled analysis, almost 15,000, again, from randomized clinical trials of shorter or longer term DAPT. And what is found here is that longer term DAPT in non-high bleeding risk patients decreased ischemic events, both in complex and non-complex PCI patients, but not among high bleeding risk patients. And TIMI bleeding risk was increased by long-term DAPT, but only in high bleeding risk patients, regardless of PCI complexity. So what do those two messages mean? Well, what that means is more than ischemic risk, bleeding should inform decision-making on DAPT duration when they are concordant, or translated into plain English. If the patient has high ischemic risk and high bleeding risk, like lots of our patients do, well, there the bleeding risk is really the more important. That dominates, that trumps the ischemic risk. You might think that that wouldn't be the case, but that's why in that older, frail patient who's at high ischemic risk, when you use really potent, prolonged, in this case, dual antiplatelet therapy, it tends to backfire. It's not that they aren't at high ischemic risk, they are, but that bleeding risk dominates. And therefore, in that type of patient, you really wouldn't want to use prolonged DAPT. But that lesson probably applies to other areas. Even if you think about aspirin for primary prevention, in the older patients, it doesn't seem to be that good, probably because even though they're at high ischemic risk, they're at proportionately higher bleeding risk. So hopefully that concept makes sense. All right, now let's go back to the clinical trials and move away from risk scores and that sort of thing, and review some of the trials that help inform whether we should or shouldn't use long-term dual antiplatelet therapy. So we know from the guidelines that a year of dual antiplatelet therapy is recommended after ACS, such as in patients who had an MI. But what should you do after that? Well, the Pegasus TIMI 54 trial addressed that question in stable patients with a history of MI, but 1 to 3 years prior, but with additional atherothrombotic risk factors. By that, I mean older age, older than 65, it's not that old, diabetes, second prior MI, other than the MI that qualified them for entry into this trial, so multiple ischemic events in the past, patients with multivessel coronary disease, or chronic non-end stage kidney dysfunction. So those were additional atherothrombotic risk factors. The patient had to have at least one in addition to that history of MI 1 to 3 years prior. And then the patients were randomized to placebo, ticagrelor 60 BID or ticagrelor 90 BID. Here's the primary endpoint of cardiovascular death, MI or stroke, a significant benefit from either dosing regimen of ticagrelor versus placebo on a background of aspirin therapy. But I should point out the US FDA actually for this indication approved ticagrelor 60 BID because it had slightly less bleeding and slightly less dyspnea than 90 BID. So similar efficacy, but slightly better side effect profile. So for this indication, 60 BID was approved, unlike acute coronary syndromes, where, as you know, 90 BID is what's used. And here are the individual endpoints. I just showed you the cardiovascular death, MI, or stroke on the prior slide. Here we can see cardiovascular death, MI, stroke. Well, for the pooled analysis of both doses, we see cardiovascular death is trending towards benefit with a p-value of 0.06. If we'd had just one dosing arm instead of two, I think that would have been a statistically significant finding. Myocardial infarction, very significantly reduced, and stroke, interestingly, was also significantly reduced. And here I'm talking about all-cause stroke. Obviously, this is ischemic stroke that's being reduced, but fortunately, there was no increase, or at least no significant increase in hemorrhagic stroke, so even overall stroke was significantly reduced. And here are those, and the rest of the bleeding data for the ticagrelor 90 BID in red, 60 BID in blue, and placebo in green. You can see there is a significant increase in TIMI major bleeding, about 2.5-fold higher than placebo. I mean, of course, the bleeding is going to be higher than placebo, but that is a significant increase in TIMI major bleeding. And as you can see, there's numerically higher bleeding with the 90 versus 60 BID. So that's why the FDA went with the 60 BID for the Pegasus indication. Fortunately, in these carefully selected trial patients, there was no significant increase in fatal bleeding or intracranial bleeding. And we did look at some subgroups within Pegasus, such as in this analysis, looking at patients with diabetes at baseline in the Pegasus trial. And again, everyone in Pegasus had a prior myocardial infarction. And you can see in the non-diabetic patients, there's a significant benefit of ticagrelor versus placebo on top of aspirin. And in the diabetes patients, well, their event rates are higher because of their diabetes, and the absolute risk reduction is a bit larger. That was for the endpoint of MACE. Here we can see coronary death, where really there isn't much of a reduction in the patients without diabetes, but in those with diabetes, there is a significant reduction, suggesting that these patients derive even greater benefit, as is consistent with the prior literature. We know that patients with diabetes are at high risk, and if they've had a prior MI, well, they're particularly high risk. This is now examining the subgroup from Pegasus of patients with peripheral artery disease. At the bottom are those without PAD, at the top are those with PAD. Consistent benefit, but again, looks like a larger absolute risk reduction in those with PAD versus without PAD. And interestingly, in Pegasus, which was a trial looking at post-MI patients, it wasn't a PAD trial, we did note that there was a significant decrease in major adverse limb events with ticagrelor versus placebo. So I showed you already significant reductions in MI, significant reductions in ischemic stroke, also significant reduction in peripheral ischemic events. So all three territories, all three circulations favorably influenced by protracted dual antiplatelet therapy. And this is just showing a consistency of benefit in the types of acute limb ischemia and peripheral ischemic events that were occurring. All right, now let me move to the THEMIS trial. This is the most recent of the trials of large-scale trials of dual antiplatelet therapy. Here, we examined 19,000 patients with diabetes without prior MI, without known prior stroke, but with angiographically proven but stable coronary artery disease, at least a 50% coronary epicardial stenosis. So coronary artery disease plus diabetes. In fact, the largest trial of diabetes done to date at 19,000 patients. And here again, we randomized patients to ticagrelor or placebo on top of aspirin. And here's the placebo, and here is the ticagrelor. And as you can see, there's a significant, in relative terms, 10%, in absolute terms, 0.7% reduction in cardiovascular death, MI, stroke. So a positive trial, but it's a modest degree of benefit, but it's in a very large unselected population. So the key here isn't to use this therapy in everybody that fit the inclusion criteria of the trial. I mean, there are a lot of patients with diabetes and coronary artery disease out there. I'm not saying use it in everybody, but in carefully selected patients at low bleeding risk and high ischemic risk from that universe, that large universe of stable CAD and diabetes, I do think there are patients that could benefit. And now let's just drill down on the data a little bit and look at the patients with a history of PCI or no history of PCI. And we see in particular the patients from THEMIS that had a history of PCI, they seem to derive even greater benefit than the overall trial. It's true for the primary endpoint. It's true for a lot of the components of the primary endpoint as well. And I'll mention that in the overall trial, but also in this subgroup of patients with PCI in their history, we see significant reductions in MI, significant reductions in STEMI, significant reductions in stroke as well. And now let's look at the same data, but let's do an on-treatment analysis. Before doing that, let me share with you what the discontinuation rates were in the trial. First of all, in the placebo arm, a quarter of the patients stopped placebo because of a perceived side effect. So it just goes to show you how people sort of assume that side effects are from a drug they're taking, even when the drug is a placebo. So 24% discontinued the placebo arm. An extra 10% of patients discontinued in the ticagrelor arm. And of those patients, 2/3 of the discontinuation were due to dyspnea, a known side effect of ticagrelor, and 1/3 of the excess in discontinuation was due to bleeding. I might have actually thought that it would have mostly been bleeding, but in fact, it was more of a dyspnea issue than a bleeding issue. So these are patients that discontinued the study drug. Let's now look at the patients that actually took the study drug, an on-treatment analysis as opposed to an intent to treat analysis. Now, there's some potential dangers of doing these sorts of analyses. This is sort of a best case scenario of patients who could actually tolerate the therapy. But what we found here in patients that could tolerate the therapy, who were adherent to it, that weren't having side effects, yes, a best case scenario, a much more robust, much larger, both in relative and absolute terms, risk reduction in cardiovascular death, MI, stroke, a 19% relative, a 1.2% absolute risk reduction in that important endpoint. So in the right patient who's tolerating DAPT without bleeding, without, in this case, dyspnea, without other side effects, who's actually adherent to it, well, this is the sort of benefits that could possibly be realized. So again, in the right patient, this seems like it could be a useful addition to their medical therapy. And we showed in THEMIS PCI for the first time just how long the benefit of dual antiplatelet therapy goes out, showing a significant benefit of dual antiplatelet therapy in the patients in THEMIS PCI out to 10 years from the time of their PCI. In fact, it was statistically significant out to about 6 to 7 years. The dark black line is the hazard ratio. This line here, if you can see my cursor, the gray line is a hazard ratio of 1. So anything under that suggests benefit. The dashed lines are 95% confidence intervals. So if they cross unity, then it's not actually statistically significant. So up to about 6 or 7 years, a statistically significant reduction in MACE from being on dual antiplatelet therapy versus aspirin. So again, these were the first data from a randomized trial to show the benefit of long-term DAPT beyond just say a year or 3 years, but really going out to, I would say, 10 years. So we also looked at limb events in the THEMIS trial. This was presented at the ESC as a late breaker a while back. And here, as with MI, as with STEMI, as with ischemic stroke, we're seeing a significant reduction in peripheral limb ischemic events. So once more, as in PEGASUS, we're seeing in THEMIS significant reductions in events affecting the heart, the brain, and the legs. And these data from THEMIS and THEMIS PCI led in the US to approval of ticagrelor to reduce the risk of a first MI or stroke in patients with coronary artery disease at high risk for such events. And actually, the FDA went beyond just diabetes patients, which is what we studied, to say any high-risk patients with coronary artery disease. And I agree with what they did, because we just picked diabetes because it's high risk, but there are other ways a patient can be high risk too, as you know. So this really distinguishes then ticagrelor, which has this approval. Of course, clopidogrel has approvals for ACS plus PCI, ACS managed medically for patients with prior MI. Prasugrel has a more limited approval for ACS managed with PCI. So great data for clopidogrel and prasugrel as well for those indications. But as you can see for ticagrelor, much broader set of indications. One other thing I'll mention about ticagrelor is that specific to ticagrelor is that it is a reversible antiplatelet agent. What does that mean? Well, it's not immediately reversible, as you know. It takes about 3 days to leave the body and for the effect to go. But in terms of how it binds to the P2Y12 receptor, there it is reversible in terms of the receptor binding kinetics. That is different from prasugrel or clopidogrel, which bind irreversibly to the ADP P2Y12 receptor. More precisely, their active metabolite binds irreversibly. So the platelet is inactivated for the lifespan of the platelet, 7 to 10 days until it's cleared by the reticuloendothelial system. Aspirin as well, through a different mechanism, is a irreversible antiplatelet agent, but ticagrelor is reversible. Does that really matter? Well, it does, because it has allowed the development of a human monoclonal antibody fragment called bintrafimab. This is something that was studied in a phase 1 trial. Phase 1 means healthy human volunteer. We published the work in New England Journal of Medicine a couple of years ago showing immediate and sustained reversal of ticagrelor with that human monoclonal antibody. And just 4 days ago, as a late breaker at the American Heart Association, I presented the REVERSE-IT data, where we looked at the same drug, bintrafimab, but in a phase 3 trial, that is actual patients, either patients undergoing surgery or with major bleeding. And I'm just going to go through this quickly, but because this drug is still investigational. But you can see here in patients, as in the healthy volunteers in the phase 1 study, it quickly and potently reverses the antiplatelet effect of ticagrelor. So assuming that this gets approved by the FDA and in other regions of the world, this could be an antidote to patients who are having bleeding on ticagrelor or who need emergency surgery. So it could be really quite useful. And ticagrelor, as you are likely aware, is going to go generic in most parts of the world sometime in the next couple of years. So I imagine its use will really increase, and having a reversal agent could really make it much safer to use than other antiplatelet agents. All right, now I'm going to switch gears for the second half of my presentation to dual pathway inhibition. This is the concept of combining an antiplatelet with an anticoagulant. This is something that had been studied in a series of trials that actually didn't look so good, but one trial I did, the COMPASS trial. And this enrolled 27,000 patients with stable coronary artery disease or peripheral artery disease and randomized them to aspirin alone, rivaroxaban alone at a dose of 5 milligrams twice a day. So that's lower than, say, the atrial fibrillation dose of 20 milligrams a day in someone with normal kidney function, so a low dose of rivaroxaban, or a very low dose of rivaroxaban, 2.5 BID plus aspirin 100 a day. So that's a very low dose of rivaroxaban. Again, for atrial fibrillation, you typically use 20 milligrams once a day of rivaroxaban in someone with normal kidney function. So this is a very low dose. And what was found was that this combination of very low dose rivaroxaban plus aspirin, what I'll call vascular dose rivaroxaban plus aspirin, significantly reduced events versus aspirin alone. I won't say much more about the black line rivaroxaban alone. That did look like it was lowering the rate of ischemic events, but that p-value wasn't significant. No regulatory filing or approval of that particular dose for this indication of patients with CAD or PAD. So everything else I'm going to say is about the blue line here, reduced dose or vascular dose rivaroxaban plus aspirin. So the overall COMPASS trial positive, a hazard ratio of 0.76. Now, looking at the individual components of the endpoint, we see that cardiovascular death was significantly reduced, stroke was significantly reduced, and MI was lower. That p-value wasn't significant, but if we look at other sorts of coronary events like sudden cardiac death and so forth and lump it together, then there was a significant reduction. But MI alone, while lower, that p-value wasn't significant. So based on these results, Dr. Braunwald actually called the COMPASS trial an important step for thrombocardiology because it opened up a new approach to treating atherosclerotic patients. We knew that anticoagulants were useful in atrial fibrillation and DVT and that sort of thing, but now we're talking about patients with atherosclerosis, CAD and PAD. So that's a big step forward. More recently from COMPASS, this is just in the past month or two, we published the mortality data. Now, the overall COMPASS trial, of course, had shown a reduction in mortality, but there was some debate around it because the p-value for that was less than 0.05, which most people would say statistically significant. But on the other hand, in our statistical analysis plan, we had pre-specified a much lower p-value to be able to claim mortality was significant. But on the other hand, the Data Safety Monitoring Board for the COMPASS trial stopped it early, in part because they saw a mortality benefit. So you can see it gets pretty complex. Was there or wasn't there a mortality benefit? Well, ultimately, at least those of us involved with the trial concluded, yes, indeed, there was a mortality benefit. You can look at the hazard ratio. That's this blue line where my arrow is pointing. The dotted lines are the 95% confidence interval. So you can see the hazard ratio here is underneath 1 soon after randomization, and then becomes clearly statistically significant by about 15 months or so. And then for the remainder of the trial is indeed statistically significant. And had the Data Safety Monitoring Board not stopped the trial early for what they called overwhelming efficacy, you can imagine that these confidence intervals would have gotten even tighter with greater duration of follow-up. So we believe there's a mortality reduction in COMPASS. Does that matter? Well, yes, because the drug causes bleeding. There's a financial cost to it. But the fact that it has a mortality benefit, assuming you believe that, sort of changes the calculus, because there you really do want to use drugs in patients where there's a mortality benefit, even if there's side effect, even if there's financial costs. Okay, that's the overall COMPASS trial. Let me now share with you COMPASS diabetes, the subgroup of patients with diabetes. First, here are the data in the patients without diabetes, where there's a significant benefit of vascular dose rivaroxaban plus aspirin versus aspirin alone. And then here are the patients with diabetes, where there's also a significant benefit. But again, because of the larger number of events, higher event rates, a numerically higher absolute risk reduction in those with versus those without diabetes for the endpoint of cardiovascular death, MI, stroke. Now let's look at all-cause death, where again, there is a consistent benefit in both these subgroups. The p-value for interaction is negative. So statistically speaking, you would have to say it's a similar benefit in these two subgroups. But on a common sense level, if you look at the absolute risk reductions, 0.6% in those without diabetes, 1.9% in those with diabetes, about a threefold numerically higher risk reduction in all-cause mortality for the patients with versus without diabetes, again with the rivaroxaban plus aspirin versus aspirin alone. And now if we look at a mega composite of ischemic events, cardiovascular death, MI, stroke, MAIL, which stands for major adverse limb events, or major vascular amputation, here you can see a significant benefit in those without diabetes, and a numerically greater benefit in those with diabetes. In both cases, significant, but even more bang for your buck, so to speak, in the patients with diabetes. Now let me move on to COMPASS PCI, where we looked at the subgroup of patients with a history of prior PCI. And to get into COMPASS, you couldn't be on dual antiplatelet therapy. You couldn't have an indication for dual antiplatelet therapy. So recently stented patients, recent ACS weren't in the trial, but there were patients that had a PCI, 3 years ago or 18 months ago or that sort of thing. So what we see, first of all, is a consistent benefit in the patients with a history of prior PCI and in those without a history of prior PCI. So the drug worked in both of these types of patients within COMPASS. Again, COMPASS being high-risk CAD or PAD patients. All-cause death as well, consistent benefit in both the patients with and without a history of prior PCI. And here we did the same thing we did in THEMIS PCI. We looked at the hazard ratios over time for CV death, MI, stroke, and for all-cause mortality. And you can see here that purple line, the dark purple line, the hazard ratio is below 1 out to 10 years, showing a benefit even 10 years after the time of that last PCI. And even all-cause mortality pretty much is showing the same thing, a benefit out to 10 years. So these are then 2 separate lines of evidence from THEMIS PCI that I showed you, and now from COMPASS PCI, both of which are showing the benefit of being on more than just aspirin alone for many years after a PCI. Again, in patients that are high ischemic risk and low bleeding risk. And this is examining the COMPASS data according to the number of enrichment criteria in the REACH registry. For the sake of time, I'm not going to get into the details of REACH. That was a large international registry of patients with atherothrombosis. But what we find here is with a greater number of risk factors, what I would call ischemic risk factors here, we see, though many of them are also bleeding risk factors like age and chronic kidney disease, we see with a greater number of factors, 1, 2, 3, 4, the CV death, MI stroke rate goes up. So does the risk of serious bleeding in red. But the important point is look at this difference between ischemic events and bleeding events. So in high-risk ischemic patients, there are patients we can identify that are indeed at high ischemic risk and at relatively low bleeding risk, not zero bleeding risk. So in fact, sometimes doctors say, oh, who are those patients? Well, yes, those patients do exist. And in terms of the REACH registry, 60,000 plus patients that were enrolled worldwide in that registry, we looked to see how many would be eligible for COMPASS. And we found that the majority would have been eligible for COMPASS. So this isn't one of those trials where the results apply to an obscure few patients. The majority of patients in this real-world registry of atherothrombosis would have been eligible for randomization in the COMPASS trial. So the COMPASS trial, while it may not have had a huge impact on clinical practice yet, maybe it will once rivaroxaban goes generic worldwide, but it does show us that there are a lot of patients that could benefit from it. Just a few more points before wrapping up and opening things up for questions. When we look at COMPASS, we see that there are a number of high-risk subgroups that seem to derive greater benefit, larger absolute risk reductions than seen in the overall trial. I mentioned the diabetes patients, but I didn't, for the sake of time, mention the chronic kidney disease patients, the stable heart failure patients, and right at the top of the pyramid, the polyvascular patients, patients with both coronary artery disease and peripheral artery disease. Those are very high-risk patients. So patients with these sorts of additional risk amplifiers derive particular benefit from the vascular dose rivaroxaban added to aspirin versus aspirin alone. And other sorts of risk determinants and ways of looking at it, patients with multivessel disease, those with recurrent ischemic events, those sorts of patients with prior peripheral revascularization, those sorts of patients, especially when they have additional risk amplifiers, are the ones that seem to really benefit from being on more than aspirin alone, in this case, dual pathway inhibition with vascular dose rivaroxaban plus aspirin. Now, then you might ask, who do you figure out should get dual pathway inhibition or dual antiplatelet therapy? Well, I think there's a world that allows a place for both these forms of therapies. There are going to be some patients that have had a recent stent or acute coronary syndrome that should, of course, per the guidelines, be on dual antiplatelet therapy. And if they're at high ischemic risk, low bleeding risk, they've tolerated their duration of DAPT, say 12 months for an acute coronary syndrome without a problem, I would, generally speaking, just continue that. On the other hand, in patients that are not on dual antiplatelet therapy, folks that are high risk CAD or PAD, especially polyvascular disease patients that have both, there I think they're very good candidates for dual pathway inhibition, assuming that they're at low bleeding risk. And there I would go with vascular dose rivaroxaban plus aspirin. Another trial I'll mention in passing is the Voyager trial that looked at patients with symptomatic PAD undergoing peripheral revascularization, randomized to placebo or rivaroxaban 2.5 BID on a background of aspirin. About half the patients also got clopidogrel for a short duration. And what the trial found was a significant reduction in ischemic events, favoring the same combination that was studied in COMPASS, dual pathway inhibition versus aspirin alone. And again, a fair number of patients also were getting clopidogrel in both arms. So another positive trial with this dosing regimen. So let me conclude then about the points I made and some other points that I couldn't make for the sake of time, but I'm happy to field in the Q&A section. So in ACS and PCI, in patients that have both, at least 12 months of dual antiplatelet therapy is still guideline recommended if there's no bleeding. But in patients who are post-MI, such as in PEGASUS, or going back in time, CHARISMA with clopidogrel and aspirin, in patients with diabetes, such as THEMIS, in those who've undergone complex stenting or have complex coronary artery disease, consider longer durations of DAPT, especially if they've tolerated 12 months and had absolutely no bleeding issues. And the patients with AFib and also undergoing PCI or ACS, there what I do is use aspirin while they're inpatients, but then discharge them on a NOAC, whatever NOAC you prefer, and generally speaking, clopidogrel. And certainly data from Augustus, where there was apixaban and clopidogrel, looked quite good. Now, if the patient's very high risk due to their ACS or complex stenting or both, if they're young and at low bleeding risk, you might consider NOAC plus ticagrelor instead of NOAC plus clopidogrel. Almost never should you do protracted triple antithrombotic therapy. In general, as I said, I stop aspirin while the patient is being discharged. You could make an argument if clopidogrel is the ADP receptor antagonist, maybe go a week of aspirin as well, but I would never or almost never go more than a month of aspirin, NOAC, and clopidogrel. And if I'm using ticagrelor, then I would not discharge on aspirin. That really would raise the bleeding risk. And in general, after a year, I would drop the antiplatelet if the patient's stable and continue the NOAC for their atrial fibrillation, which will also protect them against MI or stent thrombosis or other things you might be concerned about. If the patient's high bleeding risk post-PCI, there you can abbreviate the duration of DAPT to 3 months, such as in the Twilight trial. And at that point, ticagrelor monotherapy would be preferred, again, based on the Twilight trial, but clopidogrel monotherapy is an option. A number of trials from East Asia have nicely demonstrated that now. And finally, if patients aren't on DAPT or are at otherwise high ischemic low bleeding risk, there you might consider the COMPASS Voyager regimen of low-dose rivaroxaban, 2.5 BID, plus low-dose aspirin, 75 to 100 milligrams a day, especially in patients that also have PAD or polyvascular disease. Well, with that, I ought to close, and I made sure to leave 15 minutes for questions. Once again, thank you for the opportunity to speak to you. I'd be happy to take any questions about. Thank you.
Thank you, Dr. Bhatt, for such an excellent conference. We have some questions for you, Dr. Bhatt. If you choose a prolonged DAPT, how long do you prolong it? You prolong for 30 months, or maybe you can go for a longer time?
Yeah, that's a terrific quick question, and it's not like thinking about statins. You know, with statins, assuming the patient doesn't have contraindications or side effects, you start it, and that's for life. You never really stop it, unless there's, again, a side effect issue. With dual antiplatelet therapy, it requires a lot more thought and active involvement of the physician. You can't just say, okay, I'm going to put them on DAPT for the rest of life. Really, that decision needs to be reassessed at least every year. And if there's any new event, if the patient develops new bleeding, of course, it needs to be reassessed. If they develop cancer, you know, if their kidney function is fluctuating, you know, there are all sorts of other things that might happen that might influence that decision of how long to continue. But we've shown from Themis PCI, there seems to be a benefit significant out to 6 to 7 years after PCI, and also just numerically lower even out to a decade. So I would say long-term therapy would be indicated, but it has to be reassessed every year. But at least now we have randomized data showing, you know, some degree of efficacy out to 10 years after the event. But I would urge some degree of caution, again, have to be careful as a patient gets older. If they develop atrial fibrillation, then I wouldn't continue DAPT. I'd put them on a NOAC. You know, if, again, they're having issues with GI bleeding, you know, arteriovenous malformations, that sort of thing, again, I'd be cautious, and there I wouldn't just continue long-term DAPT. So really has to be reassessed carefully by the physician.
Thank you, Dr. Bhatt. Dr. Bhatt, I'm curious, do you use an Atlas TIMI51 strategy in some patients, and how do you decide to use that strategy of Atlas?
In ACS.
Yeah.
It's
Yes.
a great question. You know, I was part of the executive company of that, committee rather of Atlas 2, where we showed a significant benefit of the regimen we studied in COMPASS in ACS patients, including a significant reduction in all-cause mortality. But unfortunately, the US FDA didn't approve that regimen for ACS. The European Medicines Agency did approve it, but I didn't actually know anyone that was using it. And while, you know, all that was sort of being considered by physicians, prasugrel and ticagrelor came along and became part of DAPT. And in some respects, you know, the Atlas 2 trial just sort of fell into obsolescence. So nobody I know actually implemented it. But could it have been implemented? I thought it was a great strategy. Go with aspirin, generic clopidogrel, and, you know, 2.5 BID of rivaroxaban. Now, in Atlas, there was an increase in major bleeding that was significant, and also intracranial bleeding, and even in one of the arms, it looked like fatal bleeding was a little higher. So, you know, you have to be careful when you're using 3 antithrombotic agents, even if one of them is at a very low dose, as was the case in Atlas. So I think conceptually it's a good idea, but I'm not aware of anyone actually doing it, and it's off-label in most of the world. It's on-label in Europe, but again, even there, I don't know anyone doing it.
Yes, my question is because we here in Colombia, we have the indication approved for Atlas strategy. I would like to know also.
Is anyone using it? I'm curious.
Not too much. In a very few type of patients. Personally, I use that strategy maybe in some patients with ectasia and thrombus after acute coronary syndrome. So maybe in that kind of patients, I use the DAPT plus low dose of rivaroxaban. What do you think about Borapaxar?
So I think, first of all, what you just suggested, I think makes a lot of sense for that type of patient. You know, there I might use it as well. As far as Vorapaxar, is that available? Is that on your formulary?
No, it's not available.
Yeah, I think the Vorapaxar data are very important because that's yet another independent validation that in appropriately risk stratified patients, being on more than aspirin can reduce important ischemic events. And yes, there's an increase in bleeding. So I think the data are very important because it validates the concept we first saw in Charisma, albeit in subgroup analyses in Charisma. But that concept of being on more than aspirin alone in high ischemic risk patients has now been validated in Pegasus in Themis, in Compass, albeit with reduced dose anticoagulant versus antiplatelet. A variety of, and also in the Vorapaxar trials, TIMI-50. So a variety of different trials with different compounds validate that concept. Yes, in high-risk patients, they ought to be on more than aspirin alone, but there is a bleeding price to pay. Having said that, we don't actually use Vorapaxar, and I'm not aware of anyone that's actually using it these days, because it did have a high bleeding risk, and at least in the US, nobody is really, there is a company that has the drug, but they're not really pushing it or selling it, so nobody's really using it.
Dr. Bhatt, what is your strategy for therapy in patients requiring PCI with other indication for anticoagulation, for example, intracavitary thrombus, not atrial fibrillation and other indication? How do you medicate that patient?
Yeah, that's about those are high-risk patients. So for example, that might be a young person that came in with a large anterior wall MI, akinetic, but they came in late. So even if they got primary PCI, the anterior wall maybe is dead, there's some thrombus there. So that sort of patient is maybe one of the few where I would consider triple antithrombotic therapy for a while, where I might go ahead with aspirin plus clopidogrel plus anticoagulation for a month, and then continue full dose anticoagulation and an antiplatelet, perhaps clopidogrel. And in terms of what anticoagulant to use, obviously the choices are warfarin or a NOAC. Historically, we've used warfarin in that situation, but there are some small reports, including one from our center, where we did use NOACs, and it looked like the results were probably acceptable. I think maybe for patient ease, I probably would in the current era, assuming there was no contraindication in terms of the labeling in the patient, use a NOAC and clopidogrel longer term in that patient.
Dr. Bhatt, how do you see the future, foresee the docs and for the patients with biologic or mechanical valvular prosthesis? How do you see the future?
What a great question. So first of all, for tissue valves, there's a lot of variability in terms of what surgeons do. Some people use anticoagulation for 3 months, but I must say, when I was at Cleveland Clinic, for example, we never, unless there was atrial fibrillation, used anticoagulation for tissue valves. And likewise, the surgeons I have here usually aren't using anticoagulation for tissue valves. Typically, it's just aspirin alone. Maybe that's not good. I mean, there are studies using 4D CT that show that there is subclinical thrombus that can form on those surgical tissue valves, much like can happen with TAVR valves, but we're not 100% sure what that imaging abnormality represents. But as a practical point, not everyone does it. But if someone is going to use anticoagulation for tissue valves for a period of time, I think I would use a NOAC instead of warfarin in this day and age. And if someone has atrial fibrillation in a tissue valve, I would use a NOAC, again, assuming there's no contraindication to that particular NOAC in that patient. Mechanical valves is a different story. There is a place that one should still always use warfarin, or for some reason they can't use warfarin, enoxaparin or something, a low molecular weight heparin. There, it's not clear that the NOACs are safe. What data exist from some phase 2 work was a little bit scary. It looked like the NOACs weren't working well, though that was more so for dabigatran. But there are trials that are going on in the world that are kind of medium in size that are looking at NOACs again to see if they might have a role in mechanical heart valves. But until those trials are complete, presented, published, I would stick with warfarin for the mechanical heart valve, regardless of whether there is or isn't atrial fibrillation. It's for the mechanical valve. There, it's not as clear that the NOACs work as well as warfarin does. Warfarin, of course, is targeting multiple coagulation factors, whereas the factor 10A inhibitors are very specific to factor 10A, same with the 2A inhibitor. So that's one place where I would still always go with warfarin. And again, for some reason, if the patient can't take warfarin, then I would go with a full dose enoxaparin.
Okay, and some insights about the recent MASTER-DAPT trial, Dr. Bhatt.
Yeah, sure. That trial had a lot of complexity to it and a lot of different arms. I guess I would say the bottom line was it in general supported the concept of shorter durations of intense antithrombotic therapy in patients that are at higher bleeding risk. So, I sort of viewed it as confirmatory of what we, already know. So I thought it was interesting. I thought it added to the literature in that way, but it didn't really change my practice because I was already avoiding, intense multiple antithrombotics in patients that were high bleeding risk.
Okay, terrific. Thank you so much, Dr. Bhatt. I think that it has been a wonderful conference, and we hope to see you in the near future here in person. And thank you so much, Dr. Bhatt.
Yes, thank you all very much. I really, really do appreciate the invitation to have come spoken to you. Take care, everyone. Bye now.
Okay, bye-bye. Thank you.
Yes, thank you.